but I'll try and make this as understandable as possible with apologies to all the PhDs and scientists in the audience. So we just have to go back to the beginning slide. So I'm talking to you from New York. It's just after 10 o'clock here in Eastern Time, and from the Hospital of Special Surgery. So again, thanks for everybody for spending time. So I'm a consultant to Arteriosite, and so I think one of the things that we want to do is just sort of set out what we're hoping to learn from this short. What are the concerns right now in terms of the surgical treatments we have, and is there any use or any role for these biological adjuncts? We're going to look a little bit at the basic science, and I know it's going to be hard, but we'll have a look at that in terms of the intra-articular homeostasis, because I think by knowing what that is, then we might be able to alter that. We're going to look for the in vitro and in vivo studies to determine whether or not PRP and BMAC will work. And then we're going to have a quick run through our experience here at the hospital using PRP and BMAC in cartilage regeneration. So we already know that this is an incredibly common injury, far more common than we used to believe before. There's 27,000 ankle sprains in this country, and maybe up to 50% of those will end up in some form of chondral or osteochondral injury. Now, the traditional treatment paradigms of this have been repair, and we've heard about microfracture, micropicking, or replacement osteochondral grafts, or MACI, or other adjunctive therapies. And we know that there's promising short-term or medium-term results of these when we look at micropicking and or microdrilling. Over 80 to 90% of these will do well, and they'll do well particularly in terms of their symptomatology. But I think when we have a closer look at this, and we really look at second-look arthroscopy, at the histology of what we've actually recreated, or indeed looking at sort of a sensitive state-of-the-art imaging, we can see that we're not probably as good as we thought we were. And I think, you know, Hanya Thurman's publication recently looking at 5-year follow-ups, and this is really poignant. I mean, there's no 100% in biology, but this is an absolute 100% of these had cracks and fissuring. And I think that's just a harbinger for poorer clinical outcomes to come. And so the reason for that is just because we're putting in fibrocartilage, and this is a physiological grout and no more. It's a collagen type 1, and we need collagen type 2, and it just doesn't have the normal mechanical characteristics that collagen type 2 has. So when we look at replacement, then we think, well, instead of trying to repair it, then perhaps we should replace all of these. And again, the clinical outcomes here are quite good, you know, over 90%, and we heard Dr. Scranton's figures being talked about earlier on. But when you take again a critical look at this, again using sophisticated imaging, you can see that maybe 25% of the cells in the peripheral rim between the interface die at the time of implantation, and this may lead to what we talked about earlier in terms of synovial egress and cartilage failure with subchondral assist and ultimate cartilage failure. And of course, there's other problems with donor site mobility and so forth. So what we need to do is how do we improve the reparative and replacement strategies? We know, first of all, and the basic premise of any orthopedics is to improve the mechanics. Notwithstanding, now we have to look and see how can we improve the biology. And the two things that are readily available to us here in this country right now are platelet-rich plasma and bone marrow aspirate, and we'll talk a little bit about that. So we go back, and this is the basic science part of it, just to imagine that there's a crush injury to the cartilage in medial talar dome typically, and the normal cell turnover, normal apoptosis is reversed. So instead of having anti-inflammatory mediators, we now have inflammatory mediators, TNF-alpha and interleukin-1. This will, of course, set up an inflammatory response. And from the neutrophils, we'll get these elastases, which start attacking the cartilage or the surface. These lamina splendens will start being attacked. It will also start initiating inflammatory mediators and cytokines being stimulated from the synovium, and these adamantine metalloproteinases start degrading the cartilage itself. So how does the osteochondral lesion form? Well, what happens is once we get this lamina splendens being defective, we lose the negatively charged on this hydrophilic, or rather the hydrophobic properties of the cartilage now become hydrophilic, and we get water content increases, and we start getting fluid egress through the cartilage down to the subchondral bone. And as soon as we know from Henry Mencken the subchondral bone is in any way pressurized, it too starts releasing interleukins and these cytokines, and it starts up this osteoclastic process. So that's how an osteochondral lesion, we believe, is formed, and now we have to think of what do we have that may help in terms of reversing this. So if you look at the effects of PRP, we can see it has anti-inflammatory effects. So it immediately reverses the TNF-alpha and interleukin-1, so it reduces the Adamance and metalloproteinase degradation of the cartilage itself. It also has a negative feedback loop on these interleukins through the production of hyaluronan and HGF, again from the synovial membrane itself. So it has an anti-inflammatory effect, but it also has an anabolic effect. In other words, that it will prevent the cartilage degradation, and it will produce or promote neochondrogenesis by this chondrogenesis through collagen or COL1A. And that in turn will reduce bone resorption. And when we look at the effect of when we do microfracturing using PRP, we can see that the PRP will actually stimulate these mesenchymal stem cells to further dedifferentiate into type 2 collagen. So that's the basic science behind what happens in an injury, and then how we can address that with PRP. Now we look at bone marrow aspirate, and again we're back to the green slides, but effectively it has the same anti-inflammatory effect. It has the cells, which the PRP doesn't necessarily have, and again these cells will be part of that triad in terms of the mesenchymal cells to produce cartilage. So when then we think of, again, back to the triad, we have scaffold, and we have cells, and we have growth factors, so why don't we combine the two? And so when you combine the two, you can see that PRP has a positive effect on these mesenchymal stem cells, allowing them to proliferate and to produce more chondrogenesis. So again, that's sort of the basic science, a very brief run through and a very basic science. But now if we go on to look at the in vivo evidence of PRP and its role in chondrogenesis, we can see that there's various rabbit models and various animal models, and indeed some up-and-coming human models where we've seen that PRP is chondrogenic. But it's not conclusive, and to that end, we want to look at ourselves what it would do in an animal model. So we looked at a simple rabbit model where we produced an osteochondral defect, and we fill that defect with either PRP or with an oats graft and PRP, and we then looked at those rabbits at 3, 6, and 12 months. Or 3, 6, and 12 weeks rather. And you can see that in the in other words, in the oats and the donor side, which were treated with PRP, the histological ICR scores were improved significantly. So if we look at it, I think probably the best thing, and I'm not sure you have a pointer on this, we probably don't, but if you look at the picture on your left, you'll see that there's a hole. That's the control group. We took a graft from there and actually transferred that onto the rabbit knee on the right, and then we took a graft from the knee on the right and transferred that over to the medial femoral condyle on the left. So in any event, just to spin through this, you can see that on the left, where there's that hole, that wasn't treated with PRP, and the osteochondral lesion, which was treated with an oats on the other femoral condyle, was not treated with PRP, and that's filled in. If you look at the picture on the right, the hole is completely gone. It is filled in with cartilage, or it's certainly filled in with something. We don't know whether it's cartilage yet. And the oats, again, on the reciprocating femoral condyle is filled in. So I didn't explain that very well, but I think it's probably best if we look at these. If you look at the proteoglycan and COL2, which are looking at whether or not this filled in with anything useful, this is the control. This is the hole, and this was not treated with PRP. And you can see on the top left slide that it's really sort of an amorphous matrix. There's really been no osteointegration or cartilage production. Whereas if you look on the right, that defect is now filled in. There's been osseous integration, and it appears that there's been proteoglycan, and indeed on the bottom right, that may well indeed be more cartilage-like with collagen type 2. In the osteochondral graft, the thing that we're concerned about, in the top left, you can see that there's a fibrous interface between the graft and the normal host bone, whereas on the right, top right, you'll see that that interface has been completely obliterated with PRP. And as you'd expect, both graphs have significant collagen type 2. So what really that little study showed was that PRP has a positive effect on the production of proteoglycans and the production of collagen. Now we're looking at bone marrow aspirate to see whether or not there is any animal studies out there which show its effectiveness. And I think one of the most elegant studies out there is from Lisa Fortier from Cornell here in New York, and where she looked at an equine model showing that not just in proteoglycan production and collagen 2 production, but she could show this on T2 mapping, that there was an improved healing in those treated with BMAC by comparison to those who just had microfracture alone in an equine model. That's also been shown in other studies and recently by Giannini's group in Italy in human models. So we wanted to see how that was in terms of our clinical outcomes. We looked at 3 groups: microfracture alone, microfracture in bone marrow, microfracture bone marrow PRP. And we can see that their standardized outcome scorings were roughly equivalent for the 3 groups. When we looked at it at T2 mapping, you can see on the left slide that the area of the microfracture has not filled in with normal stratification in terms of cartilage. By comparison to the picture on the right, which has been treated with microfracture in bone marrow, you can see that stratification has improved. It's not perfect, but it's certainly somewhat better. When we looked at microfracture with PRP and bone marrow, we can see that in the lower right-hand corner, that again, the stratification certainly appears to have improved on T2 mapping. Now, it's too early to say. We just have 12 patients with a minimum of 1-year follow-up with this combination. Again, thinking of the scaffold, the growth factors, and the stem cells. So when we look at the oats transplant, we do a standard oats, again, as popularized by Scranton. And we looked at, again, to see how our results with the oats could be improved by the use of bone marrow aspirate. Again, standardized outcome scorings were good and equivalent to other studies. But what we're really looking for is to see whether the stratification of cartilage has been improved and whether or not we can reduce the possibility of these cystic degeneration caused by ingress between the graft. When we combined the oats with PRP and BMAC to see if we could sort of supercharge this biological adjunct, we showed that there was, again, good clinical outcome scores equivalent to the others, but there was really no great difference between the oats BMAC and oats BMAC PRP. And again, it's probably early days on that. So what does all this mean? And probably it's difficult to tell, because what we do know is, and what Celine was telling us earlier on, there are many, many different types of concentrating systems, commercial systems available out there, and we know that each of those concentrates somewhat differently, and the factors that are obtained from them are in somewhat different concentrations. And even if we were to use the same system, there's probably interpersonal variability between the time of day that we take this, between blood that we'll be taking this morning and this afternoon from me. So it's difficult to know exactly what's going on. We do know that there's probably over 1,000 different cytokines and growth factors involved, and we really have characterized less than about 30 of these. We know that most of the chondrogenic activity in BMAC and PRP is related to TGF-beta. But we don't know what all the effects or the negative effects or possibly negative feedback loops that some of these other growth factors can have. So the take-home points in this is I think that biological augmentation is promising, but it's certainly by no means a standard of treatment at this point. We have to look at what's going on in the local environment in terms of the basic science to determine how anything that we add to that milieu can affect it either positively or negatively. We need to look at better in vitro and in vivo models, and we need to support this with proper standardized clinical outcome scores. And we really do need to do more research into this. So thank you very much. That's all I have to say on that. And I suppose as a moderator, I can't really ask myself any questions, so I'll open it up to the rest of the panel if they have any questions on that stunning and very basic science.
John, Stephen Rakin, excellent talk, really educating all of us. Thank you. A question actually came up from one of the people in the audience about using visco supplementation instead of PRP, and if you have any experience with that.
Yeah, again, this is a great question. There are several studies to show that viscosupplementation or hyaluronidase in combination with these biological adjuncts may be beneficial. There's certainly some good work on a sheep model by Sherling and some other rabbit models to show that. And one of the things that we've been trying to do here is use them synergistically, as we know that hyaluronidase does several things and it works synergistically with the other biological adjuncts. The first thing that it does, anyways, it knocks out these pain cells or the nociceptor cells, so people feel better about it. But one of the things that we didn't know that it did before sort of recent research is we didn't know that it was chondrogenic, but it certainly is, and it increases this fibronectin, which again is part of the production of collagen, and it will reduce the destruction of the remaining collagen. So I think that as an adjunct, the question is, at what time do we introduce this? And if we use it in conjunction at the time of surgery, it may not be useful. So there may be a temporal sequence in which this should be added. And we're trying to actually, with industry, we've been working on that here, but we don't have the answer to that. But it is a terrific question, and I think it is something that we have to be using more often.
If no one else has a question, I'll try another one. That is, how do we try to standardize between the different companies that make these PRP and BMAC systems and the amount of PRP or actual platelets or fiber platelets that an individual patient is getting?
Well, it's that's a $60,000 question. Because it's industry driven, it's going to be very difficult to regulate it at this point because the cat is out of the bag almost. But I think that what we have to do is that anytime we report on outcomes using these systems, we have to characterize what was the baseline before it was increased or concentrated. So we don't necessarily have to name the system, but you need to know what the baseline is. So that means that any time you use it, you've got to take normal bloods and know what the values are, and then you concentrate it and know what the values were after that. And I think only by doing that, ultimately, will some of the poorer quality systems will ultimately drop off the face, and then we'll be left with the better ones. And so we really need to take control of this. And certainly, in terms of any of the editorial boards of the more serious journals are now not going to accept any publications unless they have characterized or attempted to characterize how much these concentrating systems have improved the growth factors.
John, it's Seelan here. Great talk. What are your thoughts on orthokind? You see a lot of the professional athletes going to Germany and getting the orthokind treatment. Any familiarity with it and thoughts on it?
I don't have enough familiarity to be sort of to say anything, on an authority. I think probably like anything, it's it's probably fed a little bit by the media. There is some good science behind it, but I don't have enough information to give you a definitive on it. It's not popularized in this country neither. I don't think it is. It's not FDA approved.
Right.
Have you any experience with it?
I don't. I just have a number of athletes who've asked me about it, and at least the information that I've read on it, which is sparse, seems hopeful, but I think they're using biologics with some stem cells and some kind of combination, and reportedly getting good results. And obviously it is propagated by the media, particularly when you have big athletes like Kobe and A-Rod who are getting it and reporting that their knee feels great. But I don't know if, Martin, if you guys have access to that technology down in Australia, and if so,
No.
if you or any colleagues know anything about it.
No, I've had no experience with it here. Access the Chondrogard Australia and get funded for it, but I've had no experience with it. In fact, my first exposure to it was in Dublin a few months ago. So.
Gotcha.
So I think